All right, thank you, Zero. We'll move on to Ben Rodriguez, who's also a fourth-year student here at Mount Sinai. He completed his undergraduate degree at Pepperdine in physics before coming here. He's going to present a case with Dr. Icahn of an ETB for hydrocephalus associated with the posterior fossa tumor.
Okay, can everyone can everyone see my screen? Great. Okay, thank you. Like Dr. Morgenstern said, my name is Ben Rodriguez. I'm an MS4 here at Sinai, and I'm going to present on the surgical management of hydrocephalus secondary to posterior fossa tumors. This presentation is based on a patient that I had with Dr. Gatan and Dr. Matt Carr. Our patient is a 67-year-old female. She presented to the ED with 2 months of increasing weakness and poor balance, both of which contributed to her having multiple falls. She was also experiencing fatigue and increased sleep and decreased appetite. And on exam, she was pretty severely deconditioned, but her neuroexam was really only notable for some mild left upper extremity dysmetria. Other than that, she was neurologically intact and alert and attentive. So I have the imaging here. We're looking at an MRI brain with contrast, and this is T1 post-con, and then on the left we have the axial view, and on the right we have the sagittal view. And on axial you can see this lesion that's homogeneously contrast enhancing in the posterior fossa. It measured 3.6 by 3.1 by 3.9 centimeters. And if you look at the sagittal cut, you can see that this lesion is occupying space in the fourth ventricle, and it's causing some hydrocephalus, as can be elicited by the increased volume of the lateral ventricle that you can see on the scan. So in terms of like the differential diagnosis of a posterior fossa tumor in the fourth ventricle, especially in an adult patient, we're thinking maybe a ependymoma or a subependymoma or maybe a meningioma. And in terms of management for this patient, a patient with a posterior fossa tumor that's having symptomatic hydrocephalus, the management is going to be surgical. And the reason why I chose this case is because the management of this patient is something that was new to me, especially treating hydrocephalus along with resecting a posterior fossa tumor. And so I really wanted to dig into the decision-making specifically for the management of the hydrocephalus of this patient. So first, why are we managing hydrocephalus in a patient with a posterior fossa tumor? Why not just cut the tumor out? So these are kind of like two of the landmark original studies on preoperative management of hydrocephalus in patients with posterior fossa tumors. So Albright is from 1977 and Raimondi is from 1981. And both of these cases agreed in showing that treating hydrocephalus preoperatively, either with an EVD or shunting, greatly decrease morbidity and mortality in patients with PFT. And they both agreed on the proposal of two specific features, in that when you treat the hydrocephalus, you have a lower incidence of postoperative CSF leak just because of decreased perioperative ICP. So you're not having increased pressure and you're not going to blow a leak. Also, this actually goes along with what Dr. Betterson said earlier, is this isn't mentioned much, but both authors mentioned that having treating the hydrocephalus and having lower ICP led to, Albright called it like brain relaxation, which made the resection of the tumor itself more successful. And so in terms of nowadays, what's the decision making in treating hydrocephalus in patients with posterior fossa tumors? So there's really three main interventions that we use. First is the EVD. Obviously, this is a temporary option. You can't go home with an EVD. You can't use an EVD long term. So in cases of acute hydrocephalus, whether it's due to PFT or not, you can use an EVD, and then ideally you wean off the EVD. And if not, you would have to move on to a long-term solution. And so the two long-term solutions for treatment of hydrocephalus is a VP shunt or ETV. And so for VP shunt, really the most important part about it is that you're introducing some hardware into the body. So it's definitely a definitive treatment, but in the introduction of that hardware, you're opening yourself up to having to revise the hardware or having a nidus for infection. So definitely a definitive treatment, but there are some downsides as well. Endoscopic third ventriculostomy, or ETV, kind of bypasses the ventricular system circulation. And so you don't need any outside hardware in the body. So you're avoiding that risk of infection or revision. The problem with ETVs is that you can have an unsuccessful procedure. And so if you go in and you try to, perforate the floor of the third ventricle and you can't, then you're going to have to put a shunt in anyways. And so in terms of the decision-making in this case and other cases, there is the ETV success score, which I'll show later, that can kind of quantitatively measure how likely you are to have a successful ETV placement. And so, like I said, this ETV success score is a quantitative measure based on 3 parameters: the age of the patient, the etiology of the hydrocephalus, and whether or not the patient had a previous shunt. And so you can use the patient characteristics and the characteristics of the etiology to predict whether or not you will have a successful ETV placement. And like I said, like it said earlier, I'll show again, in treating hydrocephalus for PFTs, if you have an ETV score above 80, then you want to go more towards third ventriculostomy because you're probably going to have a successful ETV. And so this is just the math in our patient. She is older than 10 years old. She has a non-tectal brain tumor, and she has not had a previous shunt. So those will add up to an ETV score of 80. So with that being said, our surgical management was, first off, for the treatment of the hydrocephalus, which I'll focus on here, we chose to do a right ETV with an EVD placement, and we were going to leave the EVD clamped. We were just going to have that in place just in case if the ETV fails, you can open up the EVD and not have to go back in a second time. And then for the resection of the posterior cranial fossa tumor itself, Dr. Icahn chose a midline suboccipital craniectomy approach. So I'm going to talk really specifically about the ETV. Like I said, as far as the setup, the patient is set up supine. Most literature says the burr hole is made at Coker's point. Dr. Icahn also likes to go maybe a little bit posterior to Coker's point, right at the coronal suture, so that you can have a better approach when entering the ventricle. Once the burr hole is performed, you'll perform a durotomy, and then neuronavigation is used to localize into the lateral ventricle and the right lateral ventricle. And it's really important that you're in the right lateral ventricle. So once you are within the ventricle, you can use some anatomical landmarks to make sure that you have the correct laterality. And those anatomical landmarks are medially, you want to see the anterior septal vein, which is labeled number 1 on this photo. And then laterally, you want to see the thalamostriate vein and the anterior caudate vein, which are labeled 3 and 4 respectively. And then once you have your bearings, you want to follow the choroid plexus, which is labeled 2 on this diagram, into the foramen of Monroe to localize yourself into the third ventricle. And then once you're in the third ventricle, there are some anatomical structures to visualize. I'll start with 3. The labeled 3 are the bilateral hypothalami, and then 4 are the mammillary bodies, and then 1 is the tuber cinereum, and then 2 is the infundibular recess. So you just want to know where those things are, and then superior to the infundibular recess is the optic chiasm. So you really want to be careful there. And then the perforation of the floor of the third ventricle in the ETV is done in the premammillary recess, so right and directly anterior to the mammillary bodies, but you want to be careful of the basilar artery complex, which is labeled here with the 3 red asterisks. So once you're perforated, you can, as you can see here, you're in the pre-pontine cistern, and then you kind of opened up that bypass in the ventricular flow. And so now that I've kind of talked through the ETV, I'll just kind of take us through the rest of the case. So once we completed the ETV placement, we flipped the patient to prone and then performed the midline suboccipital approach to access the floor of the fourth ventricle, which is where this lesion was. And interestingly enough, we walked in thinking it was going to be an ependymoma, but we got the path back recently, and it's actually a Hu grade to meningioma. So that's very interesting. And in terms of the postoperative course, Dr. Icahn was very adamant about the patient being up and out of bed as soon as possible. So just because she was deconditioned, and so a lot of our surgical decision-making was based off of her not being further deconditioned. So it's very important that she was up and out of bed post-op day 1. So now for the rest of the talk, I just want to talk a little bit more about the decision making of choosing ETVs for the treatment of hydrocephalus in PFTs, and also, and other rivaling studies. There's actually a good amount of controversy in the literature, or not controversy, but discussion in the literature based on what intervention to choose for treating hydrocephalus. So these are two studies that I found that are very recent. The MARC study is from 2018, and that was 40 adult patients that were used, that had an ETV used to treat hydrocephalus in posterior fossa tumors, and they actually had 0 failures or complications. And the paper on the right is the Salah paper from 2022, in which they had 22 patients at one institution, and they had 2 failures of ETV where they had to go back and revise and put in a shunt. But most importantly, why I added these 2 papers was to Dr. Gaton's point of getting the patient up and out of bed faster. They were looking at recovery times in patients with ETVs versus shunts, and found that patients with ETVs were able to get up and around faster. And lastly, like I said, I wanted to point to the controversy, and honestly, selfishly, for my own learning, I'd love to open up after I'm finished for conversation about this, the differences in the interventions. So there are plenty of papers that advocate for whenever possible using trying an ETV first to treat hydrocephalus in posterior fossa tumors, and then there's another line that thinks that a VP shunt we should go directly to a VP shunt because it's more definitive and you won't have to go back for 2 separate procedures in order to treat the hydrocephalus. So I just wanted to kind of open that up. But before I do that, I just want to say thank you to everybody. Thanks to Dr. Gaton and Dr. Carr for the teaching. Thank you to Ziad for also helping out, and Ansley for answering my questions in the wee hours of the morning on call. I really appreciate it. You didn't have to do that, and you did, and that was really awesome of you. And thanks to Leslie for helping me with reading MRIs as well. So I'll open up to questions now.
Ben, great job. That's a great case to choose from my perspective, because here, 22 years into my career, that was the first time I actually did this, believe it or not. I've been introduced to this by a guy named Michel Zara, who was from the pediatric hospital in Paris. And the Paris group started doing this in the 90s and published their data in 2001 in the Journal of Neurosurgery, Journal of Neurosurgery. But it was a concept that was a little foreign to me. Anyway, I know Peter has tried it and done it well. And I did it the first time on this case because of this emphasis on the patient's condition, poorly conditioned, and also the appearance of the tumor, which seemed to be very stuck to the brainstem and to the middle cerebellar peduncle, both of which are very much off limits to the healthiest human being. So this was a decision that really was made based on the overall look at the patient and what the goals of the surgery were, which were to treat her hydrocephalus. And I really enjoyed your look at this from an academic perspective to show its predictable effectiveness. And so far it's working well for her. Peter, any comments?
Yeah, that was a great talk, Ben. And I also appreciated that you dragged out those landmark papers from Raimondi and Albright, who also happen to be 2 of the named lectures for the pediatric section every year. But I think the really key observations here are that patients with posterior fossa tumors and hydrocephalus really need CSF diversion perioperatively, whether it's temporary with an EVD or permanent with an ETV or shunt. It can significantly reduce their perioperative complications, most notably CSF leak. And it just makes the surgery simpler. I think we've probably all had the experience, those of us who see these, of not having that CSF diversion, having the tumor just pushing its way out at you because of the underlying pressure. But I also, I'm definitely in the camp of trying ETVs, as I think everyone knows about me at this point. But the idea of exposing the patient to potentially 2 operations in most cases, I think better than committing them to a lifetime shunt. But giving them a chance to avoid that, I think, is a great opportunity.
And one other nuance that I wanted to talk about for everybody, but it's a little bit of